Introduction. Select to favorite. Bleeding in a child can be a diagnostic dilemma because the causes range from benign to serious. Children with mild bleeding disorders may not experience an episode of bleeding until faced with a hemostatic challenge, such as an interventional procedure or trauma. On the other hand, children without an underlying bleeding disorder commonly present with complaints of bruising and bleeding such as epistaxis or menorrhagia. Red flags for a potential bleeding disorder include bleeding or bruising out of proportion to the injury, prolonged and or recurrent bleeding, particularly with unknown cause or after a small injury or procedure, spontaneous bruising or bleeding, uncommon sites of bleeding, joints, GI, or bruising, proximal extremities, trunk, and a family history of a bleeding disorder. Consider non-accidental trauma in the child with unusual bruising patterns. See Chapter 150, Child Abuse and Neglect. Figure 144-1 provides a basic approach for the initial ED assessment of a child with bleeding. The most common bleeding disorders presenting in childhood are discussed below. Figure 144-1. Algorithm for the approach to a child with undiagnosed bleeding. APTT equals activated partial thromboplastin time. PT equals prothrombin time. VWD equals von Willebrand's disease. A flowchart outlines an algorithm for approach to a child with undiagnosed bleeding. Introduction. Select to favorite. Bleeding in a child can be a diagnostic dilemma because the causes range from benign to Factor 8. Introduction. Select to favorite. Bleeding in a child can be a diagnostic dilemma because the causes range from benign to serious. Children with mild bleeding disorders may not experience an episode of bleeding until faced with a hemostatic challenge, such as an interventional procedure or trauma. On the other hand, children without an underlying bleeding disorder commonly present with complaints of bruising and bleeding such as epistaxis or menorrhagia. Red flags for a potential bleeding disorder include bleeding or bruising out of proportion to the injury, prolonged and or recurrent bleeding, particularly with unknown cause or after a small injury or procedure, spontaneous bruising or bleeding, uncommon sites of bleeding, joints, GI, or bruising, proximal extremities, trunk, and a family history of a bleeding disorder. Consider non-accidental trauma in the child with unusual bruising patterns. See Chapter 150, Child Abuse and Neglect. Figure 144-1 provides a basic approach for the initial ED assessment of a child with bleeding. The most common bleeding disorders presenting in childhood are discussed below. Figure 144-1. Algorithm for the approach to a child with undiagnosed bleeding. APTT equals activated partial thromboplastin time. PT equals prothrombin time. VWD equals von Willebrand's disease. A flowchart outlines an algorithm for approach to a child with undiagnosed bleeding. Hemophilia. Select to favorite. A detailed discussion of hemophilia is provided in Chapter 235, Hemophilias and von Willebrand's disease. Table 144-1 provides a summary of those bleeding disorders, which are also reviewed below. Table 144-1 Coagulation disorders. View table. Select to favorite. Download, PDF. Epidemiology. Factor 8, Hemophilia A, and Factor 9, Hemophilia B, deficiencies are X-linked recessive hematologic disorders and predominantly affect males. 1/3 of cases arise from spontaneous mutations. Thus, patients may have a negative family history of bleeding disorders. These disorders are clinically indistinguishable but differ in their treatment. Clinical features. The severity of disease, and thus risk of bleeding, is defined by the factor activity as a percentage of normal, which is defined as 50% to 100%. Patients with mild disease may never spontaneously bleed but have increased bleeding with trauma, figure 144-2, whereas individuals with severe disease have spontaneous bleeding into the joints, hemarthrosis. Figure 144-3, and soft tissue, hematomas, and may develop life-threatening hemorrhage. Figure 144-2. Hemophilia A, extensive bruising in a child with Factor 8 deficiency. Photo contributed by Ralph A. Gruppo, M.D. reproduced with permission from Nuke K, Stat L, Starwa, Thurman R.J., Atlas of Emergency Medicine, 3rd ed. Copyright 2010, McGraw-Hill, Incorporated. New York. A photograph of a young child with hemophilia A shows extensive bruising on the right forehead and eyes. Figure 144-3. Hemarthrosis. A child with hemophilia A who presented with bilateral knee hemarthrosis. Reproduced with permission from Shaw B.R., Luke S.E.M., Atlas of Pediatric Emergency Medicine, Copyright 2006, McGraw-Hill, Incorporated. New York. A photograph shows bilateral knee hemarthrosis in a child with hemophilia A. Both knees of the patient show severe inflammation. Diagnosis. Most children with hemophilia have already been identified before an ED visit because of a positive family history of bleeding disorder. Prenatal testing is possible through chorionic villus sampling or amniocentesis, intracranial hemorrhage, significant hematoma after birth trauma, or prolonged and excessive bleeding after circumcision. However, some cases, especially mild hemophilia, may escape detection until the child is several years old, when symptoms are provoked by an injury or a small interventional procedure. The event precipitating initial presentation could be as minor as a trip and fall in a newly ambulatory toddler, a common age of diagnosis due to the increased activity level. Suspect hemophilia in a child who presents with spontaneous bleeding, particularly in unusual locations, for example, joints, areas not usually injured like the proximal extremities, or with bleeding that is out of proportion to the injury. Specific bleeding manifestations are listed in tables 144-1 and 235-2. Hemarthroses are the hallmark of hemophilia, accounting for 80% of bleeding episodes in severe hemophiliacs. Older children and adolescents describe a burning or tingling sensation preceding signs of hemarthrosis development. Differential diagnosis includes a spectrum of bleeding disorders. The screening test for hemophilia is an activated PTT, which will be prolonged in most patients. Platelet count, bleeding time, and prothrombin time will be normal. Quantitative factor levels confirm a diagnosis of hemophilia. Mixing studies identify whether factor inhibitors are present. Treatment. The overall treatment goal is to increase levels of the deficient factor. Treatment of hemophilia depends on the specific factor deficiency, the baseline severity of the disease, and the nature and extent of the injury. In severe hemophiliacs, regular scheduled prophylactic administration of clotting factor concentrate is a well-established practice and significantly reduces the incidence of bleeding. Even in the absence of physical findings, promptly order and initiate factor replacement for children with a presenting ED history that raises concern about high-risk sites for bleeding. A reliable adage in hemophilia is, when in doubt, treat, preferably within 2 hours. In patients with known hemophilia, coagulation studies are not necessary upon presentation for a new bleeding episode. However, a level of factor 8 or 9 or the presence of a factor inhibitor may be requested by the hematologist to assist in the patient's evaluation and treatment. The dose of factor replacement and goal level of factor percentage are based on the clinical scenario. A good rule of thumb is to aim for a desired factor level of approximately 40% to 50% following replacement. For high-risk and or life-threatening bleeds, CNS, retropharyngeal, ophthalmic, iliopsoas retroperitoneal, intra-abdominal, intrathoracic, and GI, that goal doubles to 80% to 100%. Specific factor replacement products are listed in Table 235-3, and factor replacement guidelines are listed in Table 235-4. Recombinant and human plasma-derived factors are available, and effort should be made to use the patient's home product. Treatment regimens will differ for factor 8 and factor 9 products because they have different dosing requirements and different half-lives. In most patients, 1 unit kg of factor 8 will increase the clotting activity of treated plasma by 2%. 1 unit kg of factor 9 will raise factor activity level by only 1%. Given the cost of these products, an effort should be made to use the whole unit dose. In the rare case in which factor replacement products are not immediately available, administer cryoprecipitate for factor 8 deficiency or fresh frozen plasma for factor 9 deficiency. Patients with mild hemophilia A who have been pre-tested to document a response may be treated with desmopressin instead of factor replacement. Desmopressin releases stored factor 8 from the subendothelial compartment. The use of desmopressin is particularly advantageous for pediatric patients due to its lower cost, availability in intranasal form, and the elimination of viral transmission risk as compared to frequent factor replacement. See Table 235-5 for desmopressin dosing. Of note, desmopressin is an antidiuretic. Patients must be monitored for water retention and hyponatremia. For hemophilia patients requiring surgery and scheduled to go to the operating room from the ED, factor replacement must be given beforehand to optimize factor levels. Adjunctive management for bleeding in joints and muscles should also include rest, ice, compression, elevation, and splinting. Minimal oral bleeding, for example, after dental procedures, may be treated with topical thrombin or antifibrinolytic drugs such as tranexamic acid or aminocaproic acid. Minimal anterior epistaxis may respond to conservative therapies, such as direct pressure and phenylephrine, without factor replacement. Patients, usually with severe hemophilia A, who have factor inhibitors, antibodies, may require very high doses of standard factor products to overwhelm the inhibitors present. However, some patients will need to be treated with products that bypass factor 8 and factor 9 in the clotting cascade. See Table 235-6. These include activated prothrombin complex concentrates, FIBA registered trademark, and recombinant activated factor via Novo 7 registered trademark. Complications. Hemarthrosis is the most common hemorrhagic complication of hemophilia and most commonly affects the knee, ankle, elbow, and shoulder. Minor, often unrecognized, trauma may precipitate spontaneous intra-articular hemorrhage with pain, swelling, and decreased range of motion. Unfortunately, the presence of blood in the joint precipitates a cascade of inflammation and synovial neovascularization. This increases vulnerability to bleeding and leads to synovium fibrosis, irreversible cartilage destruction, and hemophilic arthropathy. Figure 144-4. Aggressive measures must be taken to limit the number and extent of these events. Figure 144-4. Hemophilic arthropathy. Note the extensive degenerative changes. Image used with permission of A. Fitzpatrick, M.D., Cook County Hospital. Reproduced with permission from Simon R.R., Knick S.J., Emergency Orthopedics, The Extremities, 5th ed. Copyright 2007 by the McGraw-Hill Companies, Incorporated. All rights reserved. 2 radiographs depict changes in the joints due to hemophilic arthropathy. Spontaneous muscle hematomas account for 10% to 25% of hemophilia bleeds and can also present with severe pain and limited range of motion. Complications from ongoing bleeding include compartment syndrome and nerve compression. Particularly concerning are iliopsoas bleeds, which may mimic acute appendicitis or hip pathology, with radiation of pain to the back, groin, and hip. The hip is often held in flexion. Such bleeds can be particularly uncomfortable if there is compression of the femoral nerve or sacral plexus. They require aggressive factor replacement, given the potential for blood accumulation in the retroperitoneal space. The leading cause of death in children with hemophilia is intracranial hemorrhage, which can be spontaneous or occur after even mild head trauma. Because bleeding can progress slowly, patients may not yet have clinical manifestations of hemorrhage upon presentation. Maintain a high index of suspicion. Unless directed otherwise by the hematology consultant, treat all reports of head injuries, neurologic symptoms, or visible head trauma presumptively with 100% factor correction. Obtain immediate head CT imaging to identify intracranial hemorrhage. Bleeding from the GI tract is rarely severe unless a specific anatomic lesion is present. Gross hematuria may require factor replacement. Obtain urinalysis to rule out infection and renal ultrasonography to identify a serious anatomic lesion. Other uncommon but critical lesions that require aggressive factor replacement, 100% and specialist intervention to avoid massive hemorrhage or permanent injury include tonsillar bleeding, solid organ bleeding from blunt abdominal or thoracic trauma, spinal hematoma, and intraocular hemorrhage. Disposition. Consult a hematologist for all children with hemophilia and active bleeding prior to disposition. Pediatric hemophilia patients and their families are often comfortable participating in that decision because they may receive some treatments at home. Children with mild bleeding episodes may be discharged home with careful instructions and a concrete hematology follow-up appointment. Patients with moderate or severe bleeding and those with high-risk bleeds require hospital admission because close monitoring and documentation of adequate response to factor replacement are necessary and repeat doses are frequently required. Von Willebrand's disease. Select to favorite. A detailed discussion of von Willebrand's disease, VWD, is provided in Chapter 235. VWD classification and basic treatment are outlined in Table 235-7. Clinical features. VWD type 1 is usually associated with mild mucocutaneous bleeding, including easy bruising, recurrent or prolonged epistaxis, and prolonged post-procedural bleeding, for example, gingival bleeding after dental work. Menorrhagia may be the sole presenting complaint in young women. In type 3 VWD, clinical features can closely resemble those of hemophilia because significantly reduced amounts of von Willebrand factor, VWF, allow increased clearance of factor 8. In general, the severity of bleeding correlates with the degree of reduction of factor 8. Diagnosis. A high index of suspicion is necessary for the diagnosis of VWD because clinical features are mild in most patients, and mucocutaneous bleeding, for example, bruising, epistaxis, is common in childhood. History should include frequency, duration, severity, and location of bleeding, as well as concurrent medications. Note any family history of easy bleeding. ED screening labs for VWD usually reveal a normal CBC and prothrombin time, a normal or prolonged activated PTT, if factor 8 is sufficiently reduced, and low VWF levels. More specific testing includes VWF antigen, VWF ristocetin cofactor activity, VWF multimers, and factor VIII level. Bleeding time, once the gold standard for VWD diagnosis, has difficulties with reproducibility and poor sensitivity and specificity. Levels of VWF can be affected by a variety of normal, for example, stress, and medical, for example, active bleeding, conditions. Repeat testing should be done if clinical suspicion is high. Treatment. Treatment of active bleeding in a known VWD patient consists initially of localized measures to achieve hemostasis, including direct pressure on bleeding sites, packing dental extraction sites and nasal passages, and the application of topical hemostatic agents. Antifibrinolytic agents can be used to treat oral trauma. Oral contraceptive pills or an intrauterine device helps to control menorrhagia. Desmopressin, see earlier section on hemophilia treatment, which releases stored VWF from the endothelium, is the preferred initial treatment of bleeding in patients with type 1 VWD. It has no effect in those with type 3 VWD and variable effect in those with type 2. Pay attention to the fluid status of patients receiving desmopressin, because delusional hyponatremia is a rare side effect due to its antidiuretic properties. Children with type 2 or 3 VWD or type 1 with inadequate response to desmopressin usually require treatment with purified plasma-derived VWF replacement. Other emerging therapies, such as recombinant VWF concentrate, have been approved for adults but are not yet routinely used in children. In emergencies only, administer cryoprecipitate if no VWF factor VIII replacement is available. Cryoprecipitate is not recommended as standard therapy because it has a low concentration of VWF and carries infectious risks because it does not undergo viral inactivation. Advise all patients with VWD to avoid medications with known antiplatelet effects, for example, aspirin, NSAIDs. Vitamin K deficiency bleeding. Select to favorite. Vitamin K deficiency bleeding, formerly known as hemorrhagic disease of the newborn, is a neonatal bleeding coagulopathy resulting from vitamin K deficiency. Although the American Academy of Pediatrics has recommended intramuscular vitamin K prophylaxis as standard of care in newborns since 1961, there has been an increasing rate of parental refusal in the past decade. Risk factors include breastfed infants, because breast milk contains less vitamin K content than cow's milk formulas, infants with malabsorption or hepatobiliary disorders, and maternal medications, for example, phenytoin, isoniazid. In classic cases, bleeding occurs 2 to 14 days after birth. However, there are reports of cases less than 24 hours after birth and up to 12 weeks after birth. Bleeding can present as mild oozing from the umbilicus or circumcision site or as life-threatening pulmonary and intracranial hemorrhage. Although vitamin K deficiency bleeding is rare in developed countries, 30% to 60% of reported cases are associated with intracranial hemorrhage. Labs reveal a decreased hematocrit, depending upon the severity and duration of the bleed, and prolonged prothrombin time and activated PTT. Treatment is the immediate administration of 1 mg of SC, IM, or 4 vitamin K, phytonadione. The IM route places the patient at risk for a significant hematoma, whereas the 4 route carries a greater risk of an anaphylactoid reaction. Given the risk of intracranial bleeding, do not wait for laboratory results if your clinical suspicion is high. Life-threatening hemorrhage may require a transfusion of 10 to 20 ml per kilogram of fresh frozen plasma to increase serum procoagulant levels. Anemia. Select to favorite. Children may develop profoundly low hemoglobin levels, for example, 3 to 4 grams per deciliter, before coming to medical attention. Patients may be asymptomatic or present with symptoms ranging from pallor and decreased activity to congestive heart failure in an infant. This section reviews the ED diagnosis and management of some important types of anemia in children. The management of anemia due to hemorrhage is discussed in chapters 13, Approach to Traumatic Shock, and 110, Pediatric Trauma. Hemoglobin levels vary with the child's age, peaking at approximately 14 to 15 grams per deciliter in the full-term newborn period and at approximately 13 grams per deciliter, females, and approximately 15 grams per deciliter, males, in the teenage years. The dramatic increase in oxygen availability after birth briefly shuts down erythropoietin production, resulting in a physiologic nadir, or physiologic anemia, of about 9 to 11 grams per deciliter at approximately 2 months of age. Hemoglobin levels then rise steadily throughout childhood. After the first year of life, the normal reticulocyte count is 1% to 2% of circulating red blood cells, assuming normal red blood cell physiology. Refer to normal hemoglobin and red blood cell values when evaluating pediatric anemia. Add treatment of severe anemia. Children with anemia unrelated to acute blood loss rarely require blood transfusion in the ED. Some children with very low hemoglobin levels and a presentation highly consistent with iron deficiency anemia, for example, may be managed as outpatients if close follow-up is ensured. Exceptions include hemolytic anemias, bone marrow failure, hemodynamic instability, congestive heart failure, or other symptoms due to severe anemia. Obtain a hematology consultation to assist with transfusion management. The decision to transfuse must take into account whether the child has a chronic or acute anemia. Those with chronic anemias are at risk for volume overload. For children with hemoglobin less than or equal to 8 grams per deciliter and signs of hemodynamic compromise, active bleeding, or consumptive coagulopathy, consider an initial transfusion of packed red blood cells in 10 to 15 ml per kilogram aliquots. With extremely low hemoglobin levels, less than 5 grams per deciliter, due to chronic anemia, the transfusion should be small, 2 to 3 ml per kilogram packed red blood cells, and slow, 1 ml per kilogram H, with continuous monitoring and frequent reassessment. In cases of volume overload, diuretics can be considered, or an exchange transfusion can be performed in severe cases. Classification of anemia. As with adults, a differential diagnosis for anemia in childhood can be broken down into microcytic, normocytic, and macrocytic categories. See figures 231-2, 231-3, and 231-4. The pathologic causes can be classified as those that decrease red blood cell production and those that increase red blood cell destruction, in addition to blood loss and iatrogenic delusional anemia from fluid administration. To help with those differentiations, a peripheral smear and reticulocyte count should always be sent with a CBC. A more detailed differential diagnosis of anemia is provided in Table 144-2. Selected common pediatric anemias are discussed below. For a more thorough discussion of specific etiologies, see chapters 231, Anemia and Polycythemia. 233, Acquired bleeding disorders. 236, Sickle cell disease and hereditary hemolytic anemias. And 237, Acquired hemolytic anemia. Hemolytic uremic syndrome is discussed in detail in Chapter 137, Renal emergencies in children. Table 144-2 Classification of anemia. View table. Select to favorite. Download, PDF. Iron deficiency anemia. Iron deficiency anemia is the leading cause of anemia in childhood and can be profound. Healthy term infants have adequate iron storage for the first 4 to 6 months of life. After this, iron stores are depleted. Decreasing prevalence of iron deficiency anemia may be attributable, in part, to the American Academy of Pediatrics recommendations regarding iron supplementation in breastfed infants, iron-fortified formulas and infant foods, delayed use of cow's milk until after 1 year of age, and universal hemoglobin screening at 1 year of age. However, excessive whole milk feeding and poor dietary intake of iron make iron deficiency anemia a diagnosis common in the toddler years. Milk proteins may also cause a low-grade colitis with occult GI bleeding. Nutritional iron deficiency anemia is uncommon in children greater than 3 to 4 years of age and is suspicious for occult bleeding. Iron deficiency anemia is diagnosed based on clinical suspicion, with labs demonstrating a hypochromic microcytic anemia and low reticulocyte count. Iron studies help to confirm the diagnosis. For hemodynamically stable children, treatment is outpatient oral ferrous sulfate supplementation and primary care follow-up. For children with severe anemia and/or evidence of hemodynamic compromise, inpatient care may be necessary, and hematology should be consulted regarding transfusion guidelines. Parvovirus B19 infection. Parvovirus, a common virus in childhood, replicates in erythroid progenitor cells and can cause transient red cell aplasia. In the normal host, parvovirus infection may go unrecognized or be identified by its characteristic reticular rash and slap cheek appearance, erythema infectiosum, or fifth disease. See erythema infectiosum in Chapter 142, rashes in infants and children. The red cell aplasia is so short-lived that concomitant anemia is usually not discovered. However, in patients with hemoglobinopathy or hemolytic anemias such as sickle cell disease, in whom the lifespan of a red cell is decreased, even brief periods of red cell aplasia may result in severe anemia and aplastic crisis, often requiring transfusion. Transient erythroblastopenia of childhood. Transient erythroblastopenia of childhood is a gradually developing, self-resolving normocytic anemia caused by a temporary decrease in red blood cell precursors. The cause is unknown. It is most common in the toddlers and preschool age groups, but can be diagnosed in children 6 months to 10 years of age. Other cell lines should not be affected, and iron studies are normal. Bone marrow recovery usually occurs in 1 to 2 months, and transfusions are rarely needed. Autoimmune hemolytic anemia. Autoimmune hemolytic anemia is caused by the production of autoantibodies to red blood cells. In primary autoimmune hemolytic anemia, most common in infants and young children, there is no evidence of an underlying disorder. The disease may manifest after a simple viral illness. Older children are more likely to experience autoimmune hemolytic anemia secondary to an underlying systemic illness, such as malignancy, human immunodeficiency virus, or an autoimmune disorder. The clinical presentation may be abrupt and the anemia severe. White cells and platelets are unaffected, and reticulocytes are increased unless the hemolysis is sudden and recent. Labs reveal spherocytes and schistocytes on peripheral blood smear, and indirect hyperbilirubinemia, elevated lactate dehydrogenase, and urine bilirubin metabolites, hemoglobinuria in the absence of red blood cells on urine microscopy. Definitive diagnosis is made by direct Coombs test. These patients should be hospitalized, and treatment usually begins with corticosteroids. If transfusion is required, the most compatible packed red blood cells are used. Thrombocytopenia. A platelet count less than 150,000 per millimeter 3 should be considered abnormal, and patients with a count less than 20,000 per millimeter 3 are at high risk for spontaneous bleeding. Consider thrombocytopenia in patients with Pediatric, see figure 233-1A, easy bruising, epistaxis, gingival bleeding, menorrhagia, hematuria, and GI bleeding. Perform a thorough physical exam to assess for signs of systemic disease. Refer to figure 144-1 for the general approach. Common medications associated with thrombocytopenia are listed in table 233-2. Immune thrombocytopenia. Immune thrombocytopenia, previously called idiopathic thrombocytopenic purpura, is an autoimmune disorder of antiplatelet antibodies leading to platelet destruction and, in some cases, decreased megakaryocyte platelet production. In the childhood form, over 80% of cases are self-limited and resolve within 6 months, and the incidence of life-threatening bleeds is less than 0.5%. Immune thrombocytopenia lasting greater than 3 months after diagnosis is termed persistent, and the term chronic is now used for children with thrombocytopenia greater than 12 months from the time of diagnosis. The typical presentation is a preschool or school age, previously healthy child with acute onset of Pediatric and bruising, often following a viral illness. However, 25% of children present with a more insidious course. Additional symptoms and signs are typically absent and, if found, should raise your concern for different diagnoses including hematologic, rheumatologic, oncologic, and infectious diseases. Laboratory studies typically demonstrate isolated thrombocytopenia. Pharmacologic treatment is controversial and may include corticosteroids, 4-immunoglobulin, or anti-Rh-D immunoglobulin, when a registered trademark. There are limited data regarding the use of thrombopoietic agents in children. These treatment options are discussed in further detail in Chapter 233. Consult hematology prior to management, activity restrict patients, and avoid all medications with antiplatelet activity. Admission is necessary for any child with a platelet count less than 20,000 per millimeter 3, with informed medication regimen, or with spontaneous bleeding, regardless of platelet count. If steroids are given, there are a variety of dosing regimens, ranging from 2 mg per kilogram d of prednisolone for 21 days, to 30 mg per kilogram of methylprednisolone daily for 4 days, to 20 mg per meter 2/d of dexamethasone for 4 days. Steroids should be started only if the possibility of leukemia or aplastic anemia can be completely excluded on clinical grounds. Otherwise, a bone marrow aspirate is necessary to secure the diagnosis before initiating steroid therapy. 4-immunoglobulin is superior to steroids in improving platelet numbers for immune thrombocytopenia patients. The typical 4-immunoglobulin dose is 1 gram per kilogram d. Anti-Rh-D immunoglobulin is only effective in Rh-positive patients, and patients require admission due to the risk of severe intravascular hemolysis following infusion. The anti-Rh-D dose is 50 to 75 micrograms per kilogram and can lead to a 1 to 2 gram per deciliter decrease in the hemoglobin concentration. Pretreatment with acetaminophen and diphenhydramine is recommended for both 4-immunoglobulin treatments. On the rare occasion that a child with immune thrombocytopenia develops life-threatening hemorrhage, administer an immediate single-donor platelet transfusion, 2 to 3 times normal dose, along with 4-methylprednisolone and 4-immunoglobulin or anti-Rh-D. The obvious disadvantage of platelet transfusion in immune thrombocytopenia is that platelets will be rapidly consumed by circulating antiplatelet antibodies and repeat transfusions may be necessary. Neutropenia. Isolated neutropenia in childhood is caused by a heterogeneous group of disorders, ranging from transient and benign to chronic and profound immunodeficiency. Neutropenia in the oncology patient is discussed in Chapter 145, Oncologic Emergencies in Infants and Children. Neutropenia is an absolute neutrophil count less than 1,500 per millimeter 3. Lower counts can be noted in infants during the first year of life and in individuals of African and Middle Eastern descent, but count should not decrease to less than 1,000 per millimeter 3. Neutropenia can be stratified into categories that are associated with increasing risk of pyogenic infection: mild neutropenia with absolute neutrophil count of 1,000 to 1,500 per millimeter 3, moderate neutropenia with absolute neutrophil count of 500 to 1,000 per millimeter 3, and severe neutropenia with absolute neutrophil count of less than 500 per millimeter 3. Severe neutropenia places the patient at risk for life-threatening infections. Perform a thorough history and physical examination to identify initis of infection. Physical exams should include the oral mucosa, skin, ears, lungs, abdomen, and perineal region. Avoid digital rectal examinations and rectal temperatures, as well as catheter urine sampling, because these maneuvers can result in a portal of infection. Obtain a family history to evaluate for inheritable conditions. The underlying cause of isolated neutropenia is critical in defining infectious risk. A benign, transient neutropenia is quite common in healthy children and usually arises in the context of a viral infection, resolving within weeks to months. A number of medications, including antiepileptic drugs, antibiotics, antipsychotics, and antithyroid drugs, can cause severe neutropenia and comorbidities, and reports of drug-induced neutropenia quote a 2.5% to 10% mortality rate. Neutropenia due to bone marrow depletion is a known entity in the septic child. Therefore, suspect serious bacterial infection in a critically ill child with neutropenia. Typical symptoms and signs of infection, for example, purulence, may be absent in a neutropenic patient due to reduced inflammatory response. Chronic, greater than 3 months, neutropenia can be idiopathic, autoimmune, nutritional, or associated with congenital or acquired bone marrow failure. Neonates may develop a self-resolving but significant isoimmune neutropenia from maternal fetal antigen incompatibility or have placental transfer of antibodies from a mother with autoimmune neutropenia. A benign autoimmune neutropenia can also be noted during infancy or early childhood, when repeat CBCs reveal persistent neutropenia. Children with autoimmune neutropenia tend to have more frequent, rather than more severe, infections, and the neutropenia resolves spontaneously within a few years. Lack of resolution should prompt further evaluation. If severe chronic neutropenia is noted in infancy, severe congenital neutropenia and other inherited marrow failure disorders must be excluded. Distinguishing benign neutropenia from worrisome neutropenia often requires a bone marrow examination to distinguish normal versus abnormal mielopoiesis. Cyclic neutropenia, inherited as an autosomal dominant disorder, is characterized by episodic severe neutropenia on an approximately 21-day cycle. Episodes typically last 4 to 6 days. Affected children are more likely to experience fevers and non-life-threatening infections such as stomatitis, pharyngitis, cellulitis, otitis media, and lymphadenitis. They are also at high risk for more profound infections. For the otherwise healthy child with acute, asymptomatic neutropenia identified on routine CBC, close outpatient observation and serial blood counts are usually performed. Consult hematology for children with persistent neutropenia, concern for a heritable cause of neutropenia, neutropenia associated with syndromic features on clinical exam, or serious pyogenic infections associated with neutropenia. Fever in children with neutropenia, regardless of etiology, must be treated as a medical emergency with broad-spectrum antibiotics.